Hello, it's Dmitry again, and today we'll be covering the second half of the gastrointestinal chapter from the First Aid for the USMLE Step 1 2025 edition. And on the screen you can see the 2017 edition. There will be some differences, but the content will be overall very similar. So again, we'll begin on the pathology section of the chapter, talking about oral pathologies. And let me see if this is going to align correctly. So I have oral pathologies right here, talking about aphthous ulcers, etc. And your book starts talking about, let me see, Barrett esophagus, esophageal achalasia, so forth. Let me see if we can get something that's more aligned. It might just be how they organize this a little bit different. So let me go check. Acute gastritis. Okay, so it basically goes from, I think, the esophagus down. So I'll just see if I can work from there. Here we go. Let's just read it out. So, gastrointestinal pathology, oral pathologies, aphthous ulcers, also called canker sores, common oral lesions that appear as painful, shallow, round to oval ulcers covered by yellowish exudate. Recurrent aphthous stomatitis is associated with celiac disease, IBD, SLE, Behçet syndrome, and HIV infection. That's interesting. Behçet, I would assume that's it's spelled B-E-H, and then a C with a little hook at the bottom of it. I'm not sure if that's going to be Turkish or if that's like Portuguese. If it's and then E-T. Now, if it's Portuguese, I think it's pronounced like a Z, like Behçet syndrome. And if it's Turkish, I think it'd be pronounced like a ch sound. So like Behçet versus Portuguese might be Behçet. But it looks Turkish. So we'll see what that is. Behçet's disease. Silk Road disease. So I think it's probably, I don't know. I would assume it's more likely to be Turkish. Let me look that up. Wikipedia. I want to know what's the origin, because I want to know how to pronounce it correctly, right? Behçet's disease, also called Behçet, or how do you pronounce it? Behçet. Okay. Oh, maybe I'm pronouncing the Turkish wrong. Maybe Behçet. Maybe it's in Turkey, for example, it's 2 per 1,000. Okay. Why is it called that? I'm sorry, this is a very big detour, but I just want to know why it's called that. The first modern, okay. The Behçet's disease is named after Hulusi Behçet, a Turkish dermatologist. So it is Turkish. I'm pronouncing it wrong. I think it's probably Behçet instead of Behçet. So Behçet disease and HIV infection for aphthous ulcers can cause it. IBD, lupus, Behçet, and HIV, and celiac disease. What about squamous cell carcinoma? SCC, squamous cell carcinoma, most common malignancy of the oral cavity, usually affects the tongue, associated with tobacco, alcohol, HPV-16, presents as non-healing ulcer with irregular margins and raised borders. Leukoplakia, white rash, and erythroplakia, red patch, are precursor lesions. What about sialolithiasis? Again, it's S-I-A-L-O, lithiasis. So stone formation in major salivary gland ducts, parotid, submandibular, or sublingual, associated with salivary stasis, dehydration, and trauma. Presents with a recurrent pre/periprandial pain and swelling in the affected gland. The name kind of gives it away. Lithiasis referring to a stone. So it's a stone in a salivary gland, for example, like a parotid gland, submandibular, etc. What about sialodenitis? Inflammation of the salivary gland due to obstruction, infection, like Staph aureus, mumps virus, or immune-mediated mechanisms like Sjogren's syndrome. So that's sialodenitis. That's the inflammation of the salivary gland. Well, sialolithiasis means a stone of the salivary gland. Salivary gland tumors, usually benign and most commonly affects the parotid gland. Submandibular, sublingual, and minor salivary tumors are more likely to be malignant. Typically presents as a painless mass/swelling, facial paralysis where pain suggests malignant involvement. Pleomorphic adenoma, benign mixed tumor, most common salivary gland tumor, composed of chondromyxoid stroma and epithelium, and it recurs if incompletely excised or ruptured intraoperatively, may undergo malignant transformation. What about a Warthin tumor in particular? Warthin. That's W-A-R-T-H-I-N, Warthin tumor. Papillary cystadenoma, lymphomatosum. Okay, papillary cystadenoma lymphomatosum. I can see what this is called, Warthin tumor. It's a little bit easier to understand. A little bit shorter name, I should say. It's a benign cystic tumor with germinal centers, may be bilateral or multifocal, typically found in people who smoke. And here's a little learning device here. Warriors from Germany love smoking. Well, okay. So that's a Warthin tumor, germinal center, found in smokers. Okay. Mucoepidermoid carcinoma, most common malignant tumor, mucinous and squamous components. What about, there's some pictures in here as well talking about that, and then we transition over to achalasia. And you can see some of this stuff mentioned here. You can see, Warthin tumor and the mucoepidermoid carcinoma, that kind of thing. But we don't have the other stuff mentioned. We don't have aphthous mentioned here, that kind of thing. So there's more content added to this more recent edition since 2017 at some point. What about achalasia? Achalasia, failure of the lower esophageal sphincter, LES, to relax due to degeneration of the inhibitory neurons containing nitric oxide and VIP. And VIP, by the way, was specifically, let me see, I want to make sure that I'm not saying anything correctly. VIP was vasoactive intestinal polypeptide. So vasoactive intestinal polypeptide is VIP, and NO was nitric oxide. So failure of the lower esophageal sphincter to relax due to degeneration of the inhibitory neurons, NO and VIP, in the myenteric Auerbach plexus of the esophageal wall. Remember that Auerbach is the myenteric plexus, that's for the muscle, and the Meissner's plexus is the mucosal plexus, that's involved in glandular stuff. I think it's technically submucosal. Let me just make sure I'm not saying that incorrectly for Meissner's. This is not as related, but it's the other plexus that exists. Meissner's plexus is part of, also called, submucosal plexus, and it's more of a glandular thing. But here we're talking about an issue with the Auerbach, which is the myenteric or the muscular plexus of the esophageal wall. Primary is idiopathic, secondary from Chagas disease, which is to say from Trypanosoma cruzi infection, or extraesophageal malignancies, mass effect or perineoplastic. Chagas disease, this is the learning device, Chagas disease can cause achalasia. So achalasia, CHA, and achalasia, and Chagas, CHA, right? And remember, it's caused by Trypanosoma cruzi, and I think it's spread by reduvid bugs, if I'm not mistaken. This feels like a detour, but I mean, reality is they might ask you questions like this. Chagas disease, detour is spread by what kind of bug? They call them kissing bugs, but what are they actually? What's the actual species? Reduvid bugs. Yeah, reduvid, R-E-D-U-V-I-I-D, reduvid bugs. Anyway. Back to achalasia. Presents with progressive dysphagia to solids and liquids versus obstruction, primarily solids. So this is basically an issue, presents with progressive dysphagia to solids and liquids, where if it was just an obstruction, let's say something just got stuck in your throat, if something just got stuck in your throat, you probably would have an issue with really just solids, and then liquids would probably be okay, right? Because it's just like a thing getting stuck in your throat. Things could probably pass around if it's a fluid. But for achalasia, you have an issue for both solids and liquids. Associated with increased risk of esophageal cancer. Achalasia, okay. Manometry findings include uncoordinated or absent peristalsis with increased lower esophageal sphincter resting pressure. Barium swallow shows dilated esophagus with an area of distal stenosis, bird's beak appearance. As you can see in the picture right there, it looks like a little bird's beak. And the dilated part's like the bird's body. The barium swallows show dilated esophagus with an area of distal stenosis, bird's beak. Treatment for achalasia: surgery, endoscopic procedures, for example, botulinum toxin injection, and that's to relax that muscle in that area. And they say here in your old book, achalasia, absence of relaxation. Other esophageal pathologies: gastroesophageal reflux disease, or GERD, heartburn, transient decrease in lower esophageal tone, commonly presents as heartburn, regurgitation, dysphagia, may also present as chronic cough, hoarseness like laryngopharyngeal reflux, associated with asthma. Complications include erosive esophagitis, strictures, and Barrett esophagus. So what about esophagitis again? Esophagitis, inflammation of the esophageal mucosa, presents with adenophagia and or dysphagia. Types include reflux or erosive esophagitis. Most common type is secondary to GERD. Medication-induced esophagitis, secondary to bisphosphonates, tetracyclines, NSAIDs, ferrous sulfate, potassium chloride. Eosinophilic esophagitis, chronic immune-mediated eosinophil predominant, associated with atopic disorders like asthma, esophageal rings and linear furrows on endoscopy. We have infectious esophagitis, Candida, most common white pseudomembranes, HSV1 punched out ulcers, CMV, linear ulcers, associated with immunosuppression. So what they're saying is infectious esophagitis could be something like Candida infection, an HSV1 infection with punched out ulcers, a CMV infection with linear ulcers, or associated with an immunosuppression. Well, it's associated with immunosuppression. That's why you're having this bacterial colonization. Or for HSV, it would be viral, but you get the idea. What about corrosive esophagitis? Secondary to caustic ingestion. Okay, caustic ingestion. What about Plummer-Vinson syndrome? Plummer-Vinson syndrome, triad of dysphagia, iron deficiency anemia, esophageal webs, increased risk of esophageal squamous cell carcinoma, Plummer dies. Okay, may be associated with glossitis. Okay, so you might see glossitis, an esophageal web, iron deficiency anemia, squamous cell carcinoma as a possible risk factor. What about Mallory-Weiss syndrome? Do we have that on here? Yeah, we do. Mallory-Weiss syndrome. Partial thickness, longitudinal lacerations of the gastroesophageal junction confined to the mucosa and submucosa. Due to severe vomiting, often presents with hematemesis plus or minus abdominal/back pain, usually found in patients of alcohol use disorder, bulimia nervosa. Esophageal varices, dilated submucosal veins, red arrows shown in the picture B is what they're saying. Okay, yep. And I'll go down a little bit. What was it again? We're on esophageal varices. So do you see that? Yes. Okay, good. So just look at that picture right there for B. In lower third of the esophagus, secondary to portal hypertension. Common in patients with cirrhosis, may be source of life-threatening hematemesis. What about the distal esophageal spasm? Let me see, is that mentioned? Not exactly, no. Distal esophageal spasm, formerly called diffuse esophageal spasm. So did we have that? Diffuse. Also no. Doesn't look like it, no. No, it's not. Okay. Well, just imagine there was, and I'm just reading it off to you. Distal esophageal spasm, formerly called the diffuse esophageal spasm, spontaneously non-peristaltic, uncoordinated contractions of the esophagus with normal LES pressure, presents with dysphagia and angina-like contractions, angina-like chest pain. Barium swallow may reveal a corkscrew esophagus. Manometry is diagnostic. Treatment includes nitrates and calcium channel blockers. What about sclerodoma? Sclerodoma esophageal involvement. So that's probably the lower one there that's mentioned, where they say sclerodermal esophageal dysmotility. But scleroderma esophageal involvement. Esophageal smooth muscle atrophy and fibrosis leading to a decrease in the lower esophageal sphincter pressure and distal esophageal dysmotility, which leads to acid reflux and dysphagia, leading to stricture, Barrett esophagus, and aspiration. Part of the CREST syndrome. So it's part of this wider CREST syndrome that exists. Okay. What about esophageal perforation? Esophageal perforation. Most commonly iatrogenic following the esophageal instrumentation. Non-iatrogenic causes include spontaneous rupture, foreign body ingestion, trauma, and malignancy. Pneumomediastinum, which is shown in the arrows in C, but your book is different. So mine just refers to it anyways. But pneumomediastinum and subcutaneous emphysema, signs include crepitus in the neck region or in the chest wall, can indicate dissecting air. Now this goes along with Boerhaave syndrome. Boerhaave syndrome, transmural, usually distal esophageal rupture due to violent retching. So what they're saying is basically that Boerhaave syndrome, which is spelled on the top of the screen, Boerhaave, which looks Dutch, Boerhaave syndrome, is going to be kind of like a subtype of the overall esophageal perforation. I can read Boerhaave for you in your old book. Transmural, usually distal esophageal rupture with the pneumomediastinum, with David Arrow picture for that, NA. Due to the violent retching, subcutaneous emphysema may be due to dissecting air. Crepitus may be felt in the neck region or chest wall. Surgical emergency. Okay, what about Barrett esophagus? We'll go down to that now. Barrett esophagus. Barrett esophagus, specialized intestinal metaplasia, which is shown in arrow A. Replacement of the non-keratinized stratified squamous epithelium with the intestinal epithelium, which is a non-ciliated columnar with goblet cells, which is shown in picture B, in the distal esophagus. Due to the chronic gastroesophageal reflux disease called GERD, associated with increased risk of esophageal adenocarcinoma. So basically, because of the stomach acid going into the lower part of the esophagus, the distal esophagus, there's going to be this metaplastic change to look more like an intestinal epithelium. Now, it doesn't necessarily look like stomach epithelium. It looks like intestinal epithelium. Okay? It is a non-ciliated columnar with goblet cells. Before, it was a squamous cell type. What about esophageal cancer? Typically presents with progressive dysphagia, first solids, but then liquids, and weight loss. Aggressive course due to the lack of serosa in the esophageal wall, allowing rapid extension. Poor prognosis due to the advanced disease at presentation. Yeah, and that's an issue for some kinds of cancers. It's not so much that the cancer is particularly dangerous in principle if you were to find it early. It's more so that when you actually, because it's hard to find in the first place, because it's kind of like silent for the most part, if you find it very, very late, it might be too late, you know. So esophageal cancer kind of fits that presentation. It could be a poor prognosis because they usually don't find it until maybe later down the line. Now let's talk about cancer, part of the esophagus affected, risk factors, and prevalence. So squamous cell carcinoma, you'll find that in the upper 2/3 of the esophagus. Risk factors include alcohol, hot liquids, caustic strictures, smoking, achalasia, nitrosamine-rich foods. Prevalence would be more common worldwide. Okay. What about adenocarcinoma? It's found in the lower third of the esophagus, associated with chronic GERD, Barrett esophagus, obesity, and tobacco smoking. It is more common in America. Okay. And that makes sense logically because, again, the esophagus is the squamous part. And so it makes sense that the upper 2/3 is going to be squamous cell carcinoma, but only the lower third, which is more proximal to the rest of the intestinal system, is going to have that adenocarcinoma being found around, essentially. The rectum is the opposite. We were talking yesterday on stream about this chapter and how the rectum, when you have a cancer of the lower rectum, i.e. proximal to the external body, it's going to be a squamous cell carcinoma. But if you go above the pectinate line, where it's more part of the intestinal system, you know, it's more proximal to the colon and rectum and that kind of thing, more proximal to the colon, that upper part of the rectum is more prone to something like adenocarcinoma. So sort of an inversion here, where the area that's lower down, therefore closer to the stomach, is going to have more likely to have adenocarcinoma, and the upper part, which is closer to the external body, is more likely to have squamous cell carcinoma. What about gastritis? Acute gastritis, erosions can be caused by NSAIDs with a decrease in PGE2 and a decrease in gastric mucosa protection. Burns, curling ulcer, hypovolemia leading to mucosal ischemia, brain injury, Cushing ulcer leading to vagal stimulation, increased acetylcholine, and increased hydrogen ion production. Especially common among patients with alcohol use disorder and those taking daily NSAIDs, that is to say for rheumatoid arthritis, burned by the curling iron is the learning device, and always cushion the brain. Okay. If you like to use those, you're knock yourself out. You can do that if you want to. Chronic gastritis, mucosal inflammation, often leading to atrophy, hypochloridia leading to hypergastronemia, and intestinal metaplasia, which is related to an increased risk of gastric cancers. H. pylori, most common, elevated risk of peptic ulcer disease, malt lymphoma or maltoma. Affects the antrum first and spreads to the body of the stomach for H. pylori. Begins at the antrum. What about autoimmune gastritis? Autoantibodies T-cell induced to the hydrogen potassium ATPase on the parietal cells and to the intrinsic factor, leading to an increased risk of pernicious anemia, which means you're going to have a B12 deficiency, which means you're going to have megaloblastic anemia and possibly SCD, which is going to affect your central nervous system. Or your nervous system, anyway. So affects body/fundus of the stomach. We have another one called Dmitriy. Hyperplasia, Dmitriy disease. Hyperplasia of the gastric mucosa leading to the hypertrophied rugae, or wavy-like brain gyri seen, which you can see kind of there in your picture. Causes excess mucus production with resultant protein loss and parietal cell atrophy with a decrease in acid production. Precancerous. Presents with weight loss, anorexia, vomiting, epigastric pain, and edema due to loss of protein. Pronounced WAVE. So WAVE as in weight loss, anorexia, vomiting, epigastric pain, edema. Is Dmitriy disease. What about gastric cancer? Most common gastric cancer, they verbiage on this is incorrect. It should be most common gastric adenocarcinoma. Oh no, sorry, I'm incorrect. Most commonly it's going to be gastric adenocarcinoma. When you have gastric cancer, most likely it's going to be an adenocarcinoma. After that, lymphoma, GI stromal tumor. Common mutations include KIT or PDGFRA. Carcinoid, which is rare. Early aggressive local spread with the node/liver metastases often presents late with weight loss, early satiety, abdominal pain, obstruction, and in some cases acanthosis, nigricans, or lesser Trele sign, or Trela. Weapon. So weapon is the acronym, it is, but I mean the way they want you to remember it basically. So the signs of gastric cancer would be weight loss, obviously because it's cancer, early satiety, abdominal pain, obstruction, and acanthosis nigricans, or lesser Trele sign. Okay. Intestinal associated with the H. pylori, dietary nitrosamines, smoked foods common in East Asian countries, tobacco smoking, achlorhydria, chronic gastritis, commonly on lesser curvature, looks like ulcer with raised margins. Diffuse, not associated with H. pylori, most cases due to E-cadherin mutation, signet ring cells, mucin-filled cells with peripheral nuclei, stomach wall grossly thickened and leathery, linitis plastica. Virchow node, involvement of left supraclavicular node of the metastases from stomach. Krukenberg tumor, metastases to ovaries, typically bilateral, abundant mucin-secreting signet ring cells. And then Sister Mary Joseph nodule, subcutaneous paraumbilical metastasis. And Bloomer shelf, palpable mass on digital rectal exam suggesting a metastasis to the rectouterine pouch or pouch of Douglas. What about peptic ulcer disease? Well, we have gastric and duodenal ulcers. And so there's a difference between pain, H. pylori infection, mechanism, other causes, risk of carcinoma, and other. So gastric ulcer. The pain can be greater with meals, leading to weight loss. Okay. H. pylori infection found in 70% of cases. Mechanism, decreasing mucosal protection against gastric acid. It also can be caused by NSAIDs. There's an elevated risk of carcinoma. Biopsy margins to rule out malignancy. Duodenal ulcer, the pain decreases with meals, which can cause you to have weight gain. You will find an H. pylori infection in 90% of cases. Mechanism would be the decrease in mucosal protection or the increase in gastric acid secretion. It can also be caused by Zollinger-Ellison syndrome. And the risk of the risk of carcinoma is generally benign, not routinely biopsied. And other things they mentioned in your old book, they said that gastric ulcers, biopsy margins to rule out malignancy. And for duodenal ulcers, they say hypertrophy of Brunner glands. Okay. What about ulcer complications? Hemorrhage, gastric duodenal, posterior more than anterior. Most common complication, ruptured gastric ulcer on the lesser curvature of the stomach, bleeding from the left gastric artery. An ulcer on the posterior wall of the duodenum, leading to bleeding from the gastroduodenal artery. The obstruction, pyloric channel, duodenal. Perforation, duodenal, anterior more than posterior. Anterior duodenal ulcers can perforate into the anterior abdominal cavity, potentially leading to pneumoperitoneum. May see free air under the diaphragm, pneumoperitoneum, with referred pain to the shoulder via the irritation of the phrenic nerve. Remember, phrenic nerve is the origin of the pain. What about acute gastrointestinal bleeding? Do we have that here? We have upper GI bleeding, lower GI bleeding. Doesn't necessarily look like it. Let's just pretend, let me just say it out for you. Acute gastrointestinal bleeding. There's upper GI bleeding and lower GI bleeding. Upper GI bleeding originates proximal to the ligament of Treitz, 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 suspensory ligament of the duodenum, that is. Usually presents with hematemesis and or melena, associated with peptic ulcer disease, variceal hemorrhage. The lower GI bleeding originates distal to the ligament of Treitz, so basically it's distal to that same ligament. Usually presents with the hematochezia, associated with IBD, diverticulosis, angiodysplasia, hemorrhoids, and anal fissure or cancer. As the ligament of Treitz is shown in the diagram that I have on hand, just kind of hanging out right there, and you have the duodenal jejunal flexure right below it, and coming off of the what looks to be like the right crest of the diaphragm is like right proximal to it, and then it kind of branches out down. It looks like it's kind of like wrapping around the esophagus a little bit. I would just look at a diagram if I were you, just to see what the actual ligament is. But basically, if you're proximal to that, if you're above that, theoretically, we call that upper GI bleeding. So basically, most of the stomach or the esophagus is upper GI bleeding. If you're below that, if you're distal to that, I should say, then you're in the intestines and stuff. That's more like a lower GI bleeding. So I guess it's just sort of like a cutoff point for you to, is it like a kind of a way for you to kind of categorize things? It sounds a little bit arbitrary, but I guess it's a way for them to kind of categorize how you divide upper versus lower GI for those kinds of for that kind of bleeding, you know. Anyway, malabsorption syndromes can cause diarrhea, steatorrhea, weight loss, weakness, vitamin and mineral deficiencies. Screen for fecal fat. For example, using a Sedan stain. Celiac disease, also called gluten-sensitive enteropathy. Well, I certainly don't call it that, but whatever. Or celiac sprue. Autoimmune-mediated intolerance of gliadin, gluten protein found on wheat, barley, and rye, associated with HLA-DQ2 and HLA-DQ8. I ate too much. I ate too much gluten at Dairy Queen. So what they're saying is associated with the DQ2 and DQ8 HLAs. It's going to be found in persons of Northern European descent. Primarily affects distal duodenum and or proximal jejunum, leading to malabsorption and steatorrhea. You treat it with a gluten-free diet. That's how you manage it, basically. Associated with the dermatitis herpetiformis, decreasing bone density, iron deficiency anemia, moderately increased risk of malignancy like T-cell lymphoma. D-xylose test would be abnormal. Serology is positive for IgA anti-tissue transglutaminase, IgA TTG, anti-endomysial, and anti-deamidated gliadin peptide antibodies. Histology, loss of villi, mucosal atrophy, crypt hyperplasia, intraepithelial lymphocytosis. Healthy villus atrophy, intraepithelial lymphocytes, crypt hyperplasia. Gluten, gliadin, and I'm just seeing a graph right now below celiac disease showing how gluten goes to give you gliadin crosses over, goes to the tissue transglutaminase, deamidated gliadin, goes in and it causes this sort of T cell goes and presents itself from the APC to the T cell. The T cell gives off interferon gamma and IL-21, which basically causes the B cells to start being activated and produce an anti-TTG, anti-deamidated gliadin, anti-endomysial. And those are going to basically start off this sort of immune reaction, which you don't really want to have happen because you don't really want your body to attack itself. You don't really want to have a situation where you're having these, serology positive IgA, anti-tissue transglutaminase, IgA, TTG, and anti-endomysial, anti-deamidated gliadin peptide antibodies. You don't really want that happening to you, right? But it can. So if you have that, the solution is to stop consuming gluten. What about lactose intolerance? Lactose intolerance, lactase deficiency, normal appearing villi, except when secondary to injury at tips of villi, for example, viral enteritis, osmotic diarrhea, decreased stool pH, colonic bacteria ferment lactose. Lactose hydrogen breath test, positive for lactose malabsorption if post-lactose breath hydrogen values increases greater than 20 ppm compared with baseline. What about pancreatic insufficiency? Due to chronic pancreatitis, cystic fibrosis, obstructing cancer, causes malabsorption of the fat and fat-soluble vitamins. So not only are you not absorbing the fat, you're also not absorbing the fat-soluble vitamins A, D, E, and K, as well as vitamin B12, which is also not a good thing. You have a decrease in duodenal bicarbonate and pH and fecal elastase. D-xylose test would be normal though. Okay, what about tropical sprue? Similar findings as celiac sprue. Affects small bowel but responds to antibiotics. Cause is unknown but seen in residents of or recent visitors to tropics. Decrease in mucosal absorption affecting the duodenum and jejunum but can involve ileum with time, associated with megaloblastic anemia due to the folate deficiency and later the B12 deficiency. Whipple disease, infection with Tropharema whipplei, intracellular gram-positive organism, PAS positive, foamy macrophages, and intestinal lamina propria. Cardiac symptoms, arthralgias and neurologic symptoms are common. Diarrhea/steatorrhea occur later in disease course, most common in older adults. Passes the foamy whipped cream in a can. Pass the foamy whipped cream in a can, whatever. So Whipple disease, it's PAS positive, foamy, and it is going to be associated with cardiac symptoms, arthralgias, and neurologic symptoms. So what about inflammatory bowel disease? Well, there's two different kinds that we think of traditionally. We think about Crohn's disease and ulcerative colitis. And I'll go over the differences between those two because there are some meaningful differences. There's some overlap, but there is a lot of meaningful differences that you will have to figure out when you're taking a exam. And they'll ask you like, okay, here's this condition, blah, 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 and you'll know it's either Crohn's or ulcerative colitis and ask you, what is associated with this? And you have to say basically one of the other things associated with Crohn's or associated with UC, and the other symptoms are going to be all the other disease or some other thing. You just have to figure out which one's which. So we're going to go for the Crohn's disease first, and then UC. Location, gross morphology, microscopic morphology, complications, intestinal manifestation, extraintestinal manifestations, treatment, and disease activity. So, location of Crohn's disease. Any portion of the GI tract, usually the terminal ileum and colon, skip lesions, rectal sparing. That's important. Rectal sparing can be basically anywhere else, but it's going to skip around. It's not going to be this continuous thing for Crohn's disease. For Crohn's gross morphology, transmural inflammation leading to fistulas, cobblestone mucosa, creeping fat, bowel wall thickening, string sign on small bowel follow through, linear ulcers, fissures. Microscopic morphology, non-caseating granulomas, lymphoid aggregates. Complications of Crohn's, malabsorption/malnutrition, colorectal cancer with increased risk of pancolitis, fistulas, intravesical fistula, which can cause recurrent UTI and pneumonia, and pneumaturia. Phlegmon / abscess, strictures causing, you can read it for yourself. I mean, phlegmon, PHLEGMON. I'm sorry if I don't know the correct pronunciation of that. / abscess, strictures causing obstruction, perianal disease. Intestinal manifestation, diarrhea that may or may not be bloody. Extraintestinal manifestations, rash, pyoderma gangrenosum, erythema nodosum, eye inflammation, episcleritis uveitis, oral ulcerations, aphthous stomatitis, arthritis, and peripheral spondylitis. So that's shared with UC. But what also Crohn's has calcium oxalate kidney stones, inflamed intestines leading to malabsorption of fat, leading to fat binds to calcium in the intestine, leading to excess free oxalate in the intestines, leading to increased oxalate reabsorption, which combines with calcium in the kidneys, leading to gallstones, may be positive for anti-Saccharomyces cerevisiae antibodies, ASCA. How do you treat Crohn's? Glucocorticoids, azathioprine, antibiotics, for example, ciprofloxacin, metronidazole, biologics like infliximab and adalimumab. Disease activity. This part's shared with UC. Fecal calprotectin used to monitor activity and distinguish from non-inflammatory diseases like irritable bowel. Okay. And then you see some pictures right here as well. And that picture A that you see, that should be Crohn's disease. That's the barium swallow X-ray. B is what normally that stuff should look like, and then C is for UC. So that's what UC looks like. Ulcerative colitis looks like in C. Anyway, back to for UC now. Again, there's some things that are overlapping and some things that are distinct. But for UC location, colitis means it's colon inflammation. Makes sense. Colitis, colon, right, is in the colon because it's colitis. That kind of gives it away. Continuous colonic lesions, always with rectal involvement. Always with rectal involvement. What typically happens, by the way, is that it starts off around the rectum area, that kind of area, like the very distal part of the colon, and then it kind of spreads and climbs up and up and up and up through the colon all the way down, and then it reaches the ileocecal valve and will not go beyond that. So it's always reserved to only the colon, and it usually starts off in the rectum area. So that's kind of the opposite of Crohn's, because Crohn's is not continuous. It skips around. It can be basically anywhere, but it almost is never in the rectum itself. So UC is always in the rectum and only going to be in the colon and going to be continuous. Well, Crohn's disease is almost never in the rectum. It's basically not going to be in the rectum. And it could be just about anywhere else in the intestines, though. And it's going to skip around. It's not going to be this continuous pathway. So UC again, ulcerative colitis, mucosal and submucosal inflammation only. Right, that's important. It's only going to be mucosal and submucosal. It doesn't go beyond that. It's not transmural like Crohn's is. So UC, mucosal and submucosal inflammation only. Friable mucosa with superficial and or deep ulcerations. Compare that to the normal picture you see back in we're going back down again. Compare the two, normal versus UC, with the friable mucosa with superficial and or deep ulcerations. Loss of haustra, creating a lead pipe appearance on imaging. UC will have crypt abscesses / ulcers and bleeding, but they will have no granulomas. Crohn's has granulomas that are non-caseating. UC will not have granulomas at all. Both, again, have malabsorption / malnutrition, colorectal cancer, increased risk of pancreatitis, but UC has fulminant colitis and toxic megacolon and perforation. Those are possibilities you can get. For UC, you will have bloody diarrhea, which is usually painful. Contrast with Crohn's, which you may have bloody diarrhea. You could have it, maybe you don't have it. For UC, you will have bloody diarrhea. Both will have rash, pyodermal gangrenosum, erythema nodosum, eye inflammation, episcleritis, uveitis, oral ulcerations, aphthostomatitis, and arthritis peripheral spondylitis. However, UC will specifically would have things like primary sclerosing cholangitis associated with the MPO-ONCA / P-ONCA. What about treatment? For UC, you would treat it with 5-amino salicylic acid preparations, for example, mesalamine, 6-mercaptopurine, 6-MP, right? Infliximab and colectomy. So you can just remove part or whole of the colon, basically, if it's messed up. Now, again, this part is shared for UC and Crohn's. Fecal calprotectin used in monitoring activity and distinguishes from the non-inflammatory diseases, like irritable bowel. And there's a little thing here on the bottom for you to read as well. You can read. It says here, for Crohn, think of a fat granny and an old crone. Crohn's like a witch. Well, not exactly, but it can be. Sort of like a very, very old woman. Maybe she's a witch, who knows, right? But she's a crone. Skipping down a cobblestone road away from the rectal sparing. Okay. So that's Crohn's disease. Think about a fat, old granny, crone, cobblestone road thing. UC, think about ulcerative colitis causes ulcers, large intestine, continuous colorectal carcinoma, crypt abscesses, extends proximally, red diarrhea, sclerosing cholangitis. What about IBS? Well, I'm not going to go into that quite yet. I'm going to go into microscopic colitis. Microscopic colitis, which I don't even know if they mention. Maybe they do, maybe they don't. I doubt it. Okay. Microscopic colitis. Inflammatory disease of colon that causes chronic watery diarrhea. Most common in older females. Colonic mucosa appears normal on endoscopy. Histology shows lymphocytic infiltrate in lamina propria with intraepithelial lymphocytosis or thickened subepithelial collagen band. Now we can talk about IBS. Okay, irritable bowel syndrome. Recurrent abdominal pain associated with the two or more of the following. Related to defecation, change in stool frequency, change in form, consistency of stool. No structural abnormalities, most common in middle-aged females. Chronic symptoms may be diarrhea predominant, constipation predominant, or mixed. Pathophysiology is multifaceted, may be associated with fibromyalgia and mood disorders like anxiety and depression. First-line treatment is lifestyle modification and dietary changes. Appendicitis. Acute inflammation of the appendix, as shown in the blue arrow. Shown in the yellow arrows in your thing. Yellow arrows for yours. Can be due to the obstruction of the bifecalif, which is like a fecal stone, in adults, or lymphoid hyperplasia, which is in children. Proximal appendiceal lumen obstruction leading to a closed loop obstruction, which leads to an increase in intraluminal pressure, which will lead to a stimulation of visceral afferent neurofibers at T8 to T10, leading to an initial diffusion of the periumbilical pain, which leads to the inflammation which extends to the serosa and irritates the parietal peritoneum, leading to pain localized to the right lower quadrant, McBurney point, which is 1/3 of the distance from the right anterior superior iliac spine, the right ASAS, to the umbilicus. So think about where the ASIS, the right anterior superior iliac spine is, and then think about where the umbilicus is. 1/3 from the ASIS to the umbilicus on the right side, that's called the McBurney's point. It's kind of where you would think about for looking out for appendicitis. You might want to press around that area. You have pain localized at the McBurney point. Nausea, fever, may perforate, leading to peritonitis. Now, you don't necessarily want to press hard on that area if they actually have appendicitis. You have to be wary of that, but that's where you would feel pain, typically. May elicit psoas, obturator, and Rovsing signs. It says here, severe right lower quadrant pain with palpation of the left lower quadrant. Yeah, so if you do Rovsing side, they don't explain that. Well, they do explain a little bit here. If the patient's lying supine, they're on their back on a table or whatever, and you press down in the left lower quadrant, abdominal quadrant, if they feel pain in the right side, the right lower quadrant, that's a Rovsing sign positive, and that's indication of appendicitis. Guarding and rebound tenderness on exam. Treatment would be appendectomy. So now we're going to talk about diverticula of the GI tract. And so we have here diverticulum, blind pouch, which you can see in the picture in A, protruding from the alimentary tract that communicates with the lumen of the gut. Most diverticula, the esophagus, stomach, duodenum, and colon, are acquired and are termed false diverticula. Saying here, true diverticulum, all gut wall layers, out pouch, Meckel. So all layers is true diverticulum. A false diverticulum, or a pseudo-diverticulum, only the mucosa and submucosal outpouch occur, especially where vasa recta penetrate muscularis externa layer, Zenker's diverticulum. What about diverticulosis? Many false diverticula of the colon, commonly sigmoid, and it's in 50% of people over the years of 60 or older, caused by intraluminal pressure and focal weakness in colonic wall associated with the obesity and diets in low fiber, high in total fat/red meat. It's often asymptomatic or associated with vague discomfort. Complications include diverticular bleeding, which is going to show painless hematochezia, or diverticulitis. So, what about diverticulitis then? Inflammation of the diverticula with wall thickening, which is shown in the red arrows in C, but in your book it's a different picture, so they just show you a circle that's in red. So diverticulitis, inflammation of the diverticula with wall thickening, classically causing left lower quadrant pain. Fever, leukocytosis, treat with supportive care, uncomplicated, or antibiotics if complicated. Complications include abscess, fistula, colovesical fistula leading to pneumaturia, obstruction, inflammatory stenosis, perforation, white arrows in the picture C. Again, that's not really shown in your thing necessarily. So anyway, perforation leading to peritonitis, and hematochezia is rare. So hematochezia is possible but not common. It's rare for dermatitis or for diverticulitis. So what about Zenker's diverticulum? Zenker diverticulum, pharyngoesophageal false diverticulum. Esophageal dysmotility causes herniation of the mucosal tissue at an area of weakness between the thyropharyngeal and the cricopharyngeal parts of the inferior pharyngeal constrictor, Killian triangle. Presenting symptoms would be dysphagia, obstruction, gurgling, aspiration, foul breath, neck mass, most common in older adults. And you can see a little picture of that. Your book has a thing that says elder Mike has bad breath. Elderly males, inferior pharyngeal constrictor, Killian triangle, esophageal dysmotility, and halitosis. So what about Meckel diverticulum? So Meckel's now. Meckel. True diverticulum, persistence of the vitelline omphalomesentéric duct, may contain ectopic acid, secreting gastric mucosa and or pancreatic tissue. Most common congenital anomaly of the GI tract, can cause painless hematochezia and passage melena, which is less common, right lower quadrant pain, intrasusception, volvulus, or obstruction near the terminal ileum. Diagnosis would be the 99M TC protecnetate scan, also called the Meckel scan, for uptake by heterotopic gastric mucosa. The rules of twos are 2 times as likely in males, 2 times as likely males, 2 inches long, 2 feet from the ileocecal valve, 2% of the population, commonly presents in the first 2 years of life, may have 2 types of epithelia, gastric and pancreatic. What about Hirschsprung's disease? Hirschsprung's disease, congenital megacolon characterized by lack of ganglion cells / enteric nervous plexuses like Auerbach's and Meissner's plexuses in distal segments of the colon due to the failure of the neural crest cell migration associated with loss of function mutations in Rett, presents with bilious emesis, abdominal distension, and failure to pass megaconium within the 48 hours leading to chronic constipation. Normal portion of the colon proximal to the aganglionic segment is dilated, resulting in transition zone. Risk would be increased with Down syndrome, explosive expulsion of feces, squirt sign, that's kind of gross, leading to an empty rectum on digital exam. Diagnosed by absence of ganglion cells and rectal suction biopsy. Treatment would be resection, Rett mutation in the rectum. Okay, Rett mutation. What about malrotation? Malrotation right here. Malrotation, anomaly of the midgut rotation during fetal development, improper positioning of the bowel, small bowel clumped on right side and colon on the left, formation of fibrous bands, Ladd bands. Can lead to volvulus and duodenal obstruction. So it looks all kind of messed up, you know. And that can lead to, again, duodenal obstruction or volvulus, which is not good. Now, we'll be talking about volvulus in a minute, but I'll be talking about the intussusception first. Intussusception. Intussusception, telescoping of a proximal bowel segment into a distal segment, most commonly at ileocecal junction, typically seen in infants, usually idiopathic in children, less frequently due to an identifiable lead point. Idiopathic form is associated with the recent viral infections, example, adenovirus. Rotavirus vaccine leading to pyre patch hypertrophy may act as a lead point. Common lead points include children, Meckel diverticulum, small bowel wall hematoma, IgA vasculitis, and for adults, intraluminal mass/tumor. Causes small bowel obstruction and vascular compromise leading to intermittent abdominal pain, vomiting, bloody currant jelly stools. Sausage-shaped mass in the right abdomen on the exam. Patient may draw their legs to chest to ease the pain. Ultrasound/CT may show the target sign. And you can imagine what the target sign would be if you see that sort of weird telescoping presentation. You can see how they would think it's a target when you're looking at a CT scan or something like that. Yeah, kind of weird looking. So what about volvulus then? We're talking about that before. Malrotation could cause volvulus. Well, what about volvulus? Volvulus is the twisting of portion of bowel around its mesentery. Can lead to obstruction and infarction. That's an important part. It can cause infarction in addition to its obstruction, which is also not good. Can occur throughout the GI tract. Gastric volvulus is more common with abnormalities like paraesophageal hernia in adults and presents with severe abdominal pain, dry heaving, and inability to pass nasogastric tube. The midgut volvulus is more common in infants and children, i.e. minors, so midgut minors. Sigmoid volvulus, coffee bean sign and X-ray, more common in older adults, seniors. So think about sigmoid volvulus, seniors, midgut volvulus, minors. Okay. What about short bowel syndrome? Do we have that in here? We have acute mesenteric ischemia, which we talk about in a bit. Maybe they just don't have that section. Let me talk about short bowel syndrome. Inability to adequately absorb nutrients in the small intestine secondary to the significant surgical resection, for example, Crohn's disease, malignancy, trauma, malabsorption of bile salts and fat at the distal ileum, leading to postprandial voluminous diarrhea, dehydration, weight loss, anemia, calcium oxalate kidney stones. What about other intestinal disorders? For other intestinal disorders, we have acute mesenteric ischemia, Critical blockage of the intestinal blood flow, often embolic occlusion of the SMA, leading to small bowel necrosis, as you can see in the picture in A. Abdominal pain out of proportion to physical findings may see red, current jelly stools. Risk factors include AFib, atrial fibrillation, peripheral arterial disease, PAD, recent myocardial infarction, i.e., MI, or congestive heart failure, CHF. Yeah, I'm just thinking about red current jelly stool, because they say acute mesenteric ischemia can cause red current jelly stool. They say that this small bowel obstruction and vascular compromise can lead to intermittent abdominal pain, vomiting, bloody current jelly stools as well. So just be aware of that. It's not just one thing that might present like that. Just think about how it develops, and then that can give you some hints as to what's going on. What about angiodysplasia? Tortuous dilation of vessels leading to hematochezia, most often found in the right-sided colon, more common in older patients, confirmed by angiography, associated with end-stage renal disease and von Willebrand disease, aortic stenosis. What about chronic mesenteric ischemia? Intestinal angina leading to atherosclerosis of celiac artery, SMA, most commonly affected, or IMA, leading to intestinal hypoperfusion, and postprandial epigastric pain leading to food aversion and weight loss. What about colonic ischemia? Crampy abdominal pain followed by hematochezia commonly occurs in watershed areas like the splenic flexure and rectosigmoid junction. Typically affects older adults. Thumbprint sign on imaging due to the mucosal edema/hemorrhage. Ileus, intestinal hypomotility without obstruction, leading to constipation and a decrease in flatulence, or flatulence, distended/tympanic abdomen with decreased bowel sounds associated with abdominal surgeries, opiates, hypokalemia, and sepsis. No transition zone on imaging. Treatment would be bowel rest, electrolyte correction, and cholinergic drugs that simulate the intestinal motility. Necrotizing enterocolitis, seen in premature formula-fed infants with immature immune system, necrosis of intestinal mucosa, most commonly terminal ileum and proximal colon, which can lead to pneumatosis intestinalis, which is shown in the picture in my book for B, which is actually your picture's D. It can cause pneumoperitoneum and portal venous gas. What about proctitis? Proctitis, which I don't think you have that on here, but proctitis, inflammation of the rectal mucosa, usually associated with infection like Neisseria gonorrhea, chlamydia, Campylobacter, Shigella, Salmonella, HSV, CMV, IBD, or radiation. Patient reports tenesmus, rectal bleeding, and rectal pain. Proctoscopy reveals inflamed rectal mucosa, ulcers, vesicles in the case of HSV. Rectal swabs are used to detect the other infectious etiologies. Small bowel obstruction. You would think I'd mention this somewhere, right? Small bowel obstruction? They don't. Okay. Well, maybe they do somewhere else. I'm not looking around for it right now. Small bowel obstruction. Normal flow of intraluminal contents is interrupted, leading to a fluid accumulation and intestinal dilation proximal to the blockage and intestinal decompression distal to the blockage. Presents with abrupt onset of abdominal pain, nausea, vomiting, abdominal distension. Compromised blood flow due to the excessive dilation or strangulation may lead to ischemia, necrosis, or perforation, most commonly caused by intraperitoneal adhesions like fibrous band or scar tissue, fibrous band of scar tissue, tumors and hernias, and in rare cases, meconium plug in newborns, which leads to a meconium ileus. Now, upright abdominal x-ray shows air fluid levels, which is shown in picture C, which is also C for you, I believe. No, that's a different condition, I think. Looks to be, yeah, it looks like it's something different. So back to what I was saying. For small bowel obstruction, management would include gastrointestinal decompression, volume resuscitation, and bowel rest. What about small intestinal bacteria overgrowth? Small intestinal bacterial overgrowth. Abnormal bacterial overgrowth in the small intestine, normally low bacterial colony count. Risk factors include altered pH, like achlorhydria and PPI use, anatomical, for example, small bowel obstruction, adhesions, fistula, gastric bypass surgery, blind loop, Dysmotility like gastroparesis, immune-mediated like IgA deficiency or HIV, presents with bloating, flatulence, abdominal pain, chronic watery diarrhea, malabsorption, which means you have low vitamin B12, and in severe cases. Diagnosis would be carbohydrate breath test or small bowel culture. Okay, let's go back into it. So colonic polyps, growths of tissue within the colon, grossly characterized as flat, sessile, or pedunculated on the basis of protrusion into the colonic lumen, generally classified by histologic type. So histologic type and characteristics. Generally non-neoplastic. Hamartomatous polyps. Solitary lesions do not have significant risk of transformation. Growths of normal colonic tissue with distorted architecture associated with Peutz-Jeghers syndrome, and you see a picture as well for that. Your book does not happen. And juvenile polyposis. What about hyperplastic polyps? Most common, generally smaller and predominantly located in the rectosigmoid region, occasionally evolve into serrated polyps and more advanced lesions. Inflammatory pseudopolyps, due to mucosal erosion in the inflammatory bowel disease. Mucosal polyps, small, usually less than 5 millimeters, look similar to normal mucosa, clinically insignificant. Submucosal polyps may include lipomas, leiomyomas, fibromas, and other lesions. So those are the generally non-neoplastic types. So what about the potentially malignant types? Adenomatous polyps, neoplastic via chromosomal instability pathway with mutations in APC and KRAS. Tubular histology has less malignant potential than the villus type, and villus is being shown in picture, I think, C for you, and the tubular shown in picture B. Villus histology is villainous. Yeah, well, villus is worse. It's less common though. Tubular villus has intermediate malignant potential, and usually asymptomatic, may present with occult bleeding. Yeah, so basically, if you think about it, tubular villus is sort of the intermediates, like the 25% to 75%, while the villus and the tubular is like the extremes, basically. But tubular is the least dangerous, but the most common, and then the villus is the least common, but the most dangerous. Serrated polyps. Serrated polyps, neoplastic, characterized by CpG island methylator phenotype, CIMP, cytosine base followed by the guanine, linked by the phosphodiester bond. Defect may silence mismatch repair gene, for example, MLHI. And the MLH1 expression. Mutations lead to microsatellite instability and mutations in BRAF and BRAF, sawtooth patterns of crypts on biopsy, up to 20% of cases of sporadic CRC. Polyposis syndromes. So polyposis syndromes. Familial edematous polyposis. Autosomal dominant mutations of the APC tumor suppressor gene on chromosomes 5q21 to q22.2 hit. Hypothesis. Thousands of polyps arise starting after puberty, pancolonic, always involves a rectum, prophylactic colectomy, or else 100% progress to CRC, which is, I think, colorectal carcinoma. Gardner syndrome, FAP positive, FAP positive, osseous and soft tissue tumors, osteomas of skull or mandible, congenital hypertrophy of the retinal pigment epithelium, impacted supernumerary teeth, impacted/supernumerary teeth. Yeah, Gardner syndrome is very weird. If you look at the teeth, it's very, very strange. But it's also fat positive. It's also osseous and soft tissue tumors. Turcot syndrome, fat or Lynch syndrome, plus malignant CNS tumor like medulloblastoma or glioma. Turcot, turbin. I'm not sure what the connection between those two are. Turcot, turbin. Yeah, I don't know. Putz-Jaeger syndrome, autosomal dominant syndrome featuring numerous hematomatous polyps throughout the GI tract, along with hyperpigmented macules on the mouth and lips, hands, and genitalia. You can look that up. You want to see the Putz-Jaeger syndrome and look at the lips, for example. It's these dark spots on the lips, which is interesting. Associated with the increased risk of breast and GI cancers, colorectal, stomach, small bowel, pancreatic. What about juvenile polyposis syndrome? Autosomal dominant syndrome in children, typically less than 5 years of age, featuring numerous hematomatous polyps in the colon, stomach, or small bowel, associated with the increased risk of colorectal carcinoma. What about MUTYH associated polyposis syndrome? Autosomal recessive disorder of the MUTYH genes responsible for the DNA repair, associated with significantly increased risk of CRC. Polyps, edematous, may be hyperplastic or serrated, and serrated adenomas, also associated with the duodenal adenomas, ovarian, and bladder cancers. So what about Lynch syndrome? Lynch syndrome, also called hereditary non-polyposis colorectal cancer, HNPCC. Just call it Lynch syndrome, okay? Hereditary non-polyposis colorectal cancer. Okay, man. Autosomal dominant mutation of mismatched repair genes, MLH1 and MSH2, with the subsequent microsatellite instability, 80% progress to CRC, colorectal carcinoma. Proximal colon is always involved, associated with the endometrial, ovarian, and skin cancers. Merrill Lynch has CEOs. Fine. So Lynch syndrome, you will have proximal colon is always involved, associated with the endometrial, ovarian, and skin cancers. And it's an issue of MLH1 and MSH2, which are repair genes for mismatch repair. What about colorectal cancer? So you can kind of see how we've been moving down the line. We've been talking about oral to esophageal to gastric to intestinal. Now we're in colorectal cancer. Epidemiology. Most patients are greater than 50 years of age. 25% have a family history. Risk factors include edematous and serrated polyps, familial cancer syndromes, IBD, tobacco use, diet of processed meat with low fiber. Presentation. Rectosigmoid greater than ascending, greater than descending. Most are asymptomatic, right side cecal ascending, associated with the occult bleeding, left side rectosigmoid associated with the hematochezia and obstruction, narrower lumen leading to a decrease in stool caliber. The ascending, which is exophytic mass, iron deficiency anemia, and weight loss. The descending, infiltrating mass, partial obstruction, colicky pain, hematochezia. Can present with strep bovis, which is galolyticus, bacteremia, endocarditis, or an episode of diverticulitis. What they're saying here is that strep galolyticus or Staph bovis, this is the same thing. For the most part, it's basically the same thing. For whatever reason, strep bovis is associated with colorectal cancer. I don't know the specifics as to why, but it is associated with it. It can lead up to it for some reason. Diagnosis of colorectal cancer. Iron deficiency anemia in males, especially greater than 50 years of age, and postmenopausal females raises suspicion. Screening, average risk screen at age 45 of colonoscopy, polyp seen in the picture A. Alternatives include flexible sigmoidoscopy, fecal occult blood test, FOBT, fecal immunochemical testing, which is FIT, fit fecal DNA, CT colonoscopy. But patients with a first-degree relative who has colon cancer screen at 40 years of colonoscopy or 10 years prior to the relative's presentation. Patients with IBD screen 8 years after onset. Apple core lesion seen on barium enema X-ray, which is shown in picture B. CEA tumor marker, good for monitoring recurrence, should not be used for screening. So CEA tumor marker can be used for recurrence, but not for initial screening. And the core apple core thing you're talking about right there is that's like the core center part of the apple, and you can see it's kind of out widened on both top and bottom. So that's the idea behind that. Okay. Molecular pathogenesis of colorectal cancer. Chromosomal instability pathway, mutations in the APC cause FAP and most sporadic causes of CRC, commonly left-sided, via the adenoma-carcinoma sequence. Microsatellite instability pathway, mutations or methylation of the mismatch repair genes MLH1 cause Lynch syndrome and some sporadic CRC, commonly right-sided, via the serrated polyp pathway. Overexpression of COX-2 has been linked to CRC, NSAIDs, and may be chemopreventative. Chromosomal instability pathway. Always kill polyps. Normal colon leading to loss of APC gene with colon at risk. KRAS mutation leading to adenoma. Loss of tumor suppressor genes, TP53, DCC, leading to carcinoma. So that's important. Be aware of APC, KRAS, P53, and DCC. Always kill polyps. Okay. AK53, I guess. I don't know. AP or AKP. So when you have the loss of the APC gene, decreased intracellular adhesion, increased proliferation, KRAS mutation, unregulated intracellular signaling, and for increase in tumorigenesis, for loss of tumor suppressor gene, we have increased tumorigenesis, and that's when you get the carcinoma at that point. Okay, it's good to know. I always get that stuff confused a lot of the time. Which gene we're talking about? APC, KRAS, P53, that kind of thing. Cirrhosis and portal hypertension. Cirrhosis, diffuse bridging fibrosis via the stellate cells, and regenerative nodules disrupt normal architecture of the liver. Let's see. Increased risk for hepatocellular carcinoma can lead to various systemic changes. Etiologies include alcohol, non-alcoholic steatohepatitis, chronic viral hepatitis, autoimmune hepatitis, biliary disease, genetic metabolic disorders. Portal hypertension, increased risk in portal vein system leading to a new collateral circulation, which leads to collateral vessels. Varices, esophageal, gastric, and rectal, causes cirrhosis, most common, schistosomiasis, portal vein thrombosis. Ascites, pathological fluid accumulation in the peritoneal cavity due to the portal hypertension and portal vein thrombosis. Increased hepatic sinusoidal pressure leading to ascites. Serum to ascites albumin gradients, SAAG, analysis of acidic fluid sample determines between the etiologies of ascites. SAAG is greater than or equal to 1.1, which equals portal hypertension. So if it's greater than 1.1, it's going to be portal hypertension. There's a little diagram right there showing the different kinds of effects, which include integumentary, jaundice, spiderangiomas, pulmonary erythema, purpura, petechiae, the effects of portal hypertension, which include esophageal and gastric varices leading to hematemesis and melena, the vascular, which includes caput medusa, which is the Medusa's head presentation with a little snake basically crawling across the abdomen, anorectal varices, ascites, spontaneous bacterial peritonitis. Reproductive would be testicular atrophy, gynecomastia, and amenorrhea. And those are because the testicular atrophy and the gynecomastia, and also for that matter, spiderangiomas and the pulmonary erythema, those are caused by elevated estrogen as a consequence of this condition. Neurologic would be hepatic encephalopathy, asterixis, which is flapping tremor. Gastrointestinal would be anorexia, nausea and vomiting, dull abdominal pain, and fetor hepaticus. Hematologic would be thrombocytopenia, anemia, coagulation disorders, and splenomegaly. Renal would be hepatorenal syndrome. Metabolic would be hyperbilirubinemia and hyponatremia. Cardiovascular would be cardiomyopathy and peripheral edema. So a lot of different things can be caused by this cirrhosis. going to go take a brief break. Okay. I'm going to go on to Budd-Chiari syndrome, which is going to be not on this page, or maybe it is, or maybe it's not even mentioned. Something that you should be aware of, actually. Or here it is, Budd-Chiari syndrome. So Budd-Chiari syndrome, hepatic venous outflow tract obstruction, for example, that is to say due to thrombosis or compression, with central lobular congestion and necrosis, leading to congestive liver disease, hepatomegaly, ascites, varices, abdominal pain, liver failure. Absence of JVD, associated with the hypercoagulable states, polycythemia vera, postpartum state, hepatocellular carcinoma, may cause nutmeg liver mottled appearance. Portal vein thrombosis, thrombosis in portal vein proximal to the liver, usually asymptomatic in the majority of patients, but associated with the portal hypertension, abdominal pain, and fever. May lead to bowel ischemia if extension to the superior mesenteric vein. Etiologies include cirrhosis, malignancy, pancreatitis, and sepsis. Budd-Chiari syndrome, hepatosplenomegaly. Portal vein thrombosis, no hepatomegaly unless pre-existing liver disease. Let's go back to spontaneous bacterial peritonitis. So spontaneous bacterial peritonitis, also called primary bacterial peritonitis, common and potentially fatal bacterial infection in patients with cirrhosis and ascites, often asymptomatic, but can cause fevers, chills, abdominal pain, ileus, or worsening encephalopathy, commonly caused by gram-negative organisms like E. coli or Klebsiella, or less commonly gram-positive streptococcus. Diagnosis: paracentesis with acidic fluid absolute neutrophil count ANC greater than 250 cells per cubic millimeter. Empiric first-line treatment is third-generation cephalosporins like ceftriaxone. Serum markers of liver pathology. So we have a few of these on here. We have aspartate aminotransferase, which is, I believe, AST, and alanine aminotransferase, which is ALT. So these are going to be increased in most liver diseases with ALT greater than AST, but an increase in alcoholic liver disease, but the AST is greater than the AST for most liver diseases, they're going to be high, but the ALT will be greater than the AST, except in alcoholism. When you have alcoholic liver disease, the AST will be greater than the ALT. Ratio usually is greater than 2 to 1. AST does not typically exceed 500 UL. In alcoholic hepatitis, make a toast with alcohol. Okay. AST greater than ALT in the non-alcoholic liver disease suggests progression to the advanced fibrosis or cirrhosis and significant increase in aminotransferases greater than 1000 UL. Differential includes drug-induced liver injury, that's to say acetaminophen toxicity, ischemic hepatitis, acute viral hepatitis, and autoimmune hepatitis. What about ALK-PHOS, alkaline phosphatase? Increase in cholestasis, biliary obstruction, infiltrative disorders, and bone disease. What about gamma-glutamyl transpeptidase? You have an increase in various liver and biliary diseases, just like ALP can, but not in bone disease, which located in the canalicular membrane of hepatocytes like ALP, associated with alcohol use. What about functional liver maneuvers? Functional liver markers. It makes a little bit more sense. Bilirubin, increase in various liver diseases like biliary obstruction, alcoholic or viral hepatitis, cirrhosis, hemolysis of bilirubin. Hemolysis is basically when you have bilirubin is elevated, you're either going to be hemolysis, you're breaking down RBCs, or you have a liver disease of some kind. What about albumin? Albumin is going to be decrease in advanced liver disease because it's a marker of liver's biosynthetic function, i.e., because albumin is made in the liver. If you don't have a lot of albumin, it might be because your liver doesn't function correctly. Now, it also could be because you're losing albumin in your urine because of some sort of nephron issue, but that's neither here nor there. Prothrombin time, PT. Elevated in advanced liver disease with a decreased production of clotting factors, thereby measuring the liver's biosynthetic function also. What about platelets? Decrease in advanced liver disease with a decrease in thrombopoietin, liver sequestration, and portal hypertension, splenomegaly, and splenic sequestration. Reye syndrome, R-E-Y-E. Reye syndrome, rare, often fatal childhood hepatic encephalopathy, associated with the viral infection, especially VZV and influenza, that has been treated with aspirin. Aspirin metabolites decrease the beta oxidation by reversible inhibition of mitochondrial enzymes. Findings would be mitochondrial abnormalities, fatty liver, microvesicular fatty changes, hyperammonemia, hypoglycemia, vomiting, hepatomegaly, coma. Elevated ICP, increased morbidity and mortality, renal and cardiac failure may also occur. Avoid aspirin, ASA in children except in Kawasaki disease. Salicylates aren't a ray of sunshine for kids. Steatosis of liver / hepatocytes, hypoglycemia / hepatomegaly, infection, VZV, influenza, not awake, coma, encephalopathy, and diffuse cerebral edema. Alcoholic liver disease. Alcoholic liver disease, excess NADH production leading to a decrease in fatty acid oxidation and an increase in lipogenesis. Hepatic steatosis, macrovesicular fatty change, which you can see, I believe, in picture A for you, may be reversible with alcohol cessation. Alcoholic hepatitis requires sustained long-term consumption, swollen and necrotic hepatocytes with neutrophilic infiltration, Mallory bodies, which are shown in picture B, intracytoplasmic eosinophilic inclusions of damaged keratin filaments. And what about alcoholic cirrhosis? Final and usually irreversible form of the alcoholic liver disease. Sclerosis around the central vein may be seen in early disease. Regenerative nodules surrounded by fibrous bands in the red arrows, as you can see in picture C. In response to chronic, well, yours doesn't have the red arrows. The arrows are, I think, black in yours. In response to chronic liver injury leading to portal hypertension and end-stage liver disease. So remember, the stages are going to be basically hepatic steatosis, then it goes into hepatitis, then it goes into cirrhosis. And once you get to cirrhosis, it's irreversible typically. I'm going to go a little bit further into it and talk about steatotic liver disease. Steatotic liver disease, known as SLD, encompasses metabolic. Let me see. Is there anything on this? I don't know. I'll just leave it here. So static liver disease, SLD, encompasses metabolic dysfunction associated with SLD, MASLD, formerly known as non-alcoholic fatty liver disease, which is what your book calls it, MASLD, and increased alcohol intake, alcohol-associated liver disease, specific etiology SLD, and cryptogenic SLD. MASLD is associated with the metabolic syndrome, obesity, insulin resistance, hypertension, hypertriglyceridemia, decrease in HDL. Obesity leading to fatty infiltration of the hepatocytes, which you can see in, well, your book is a little bit different, but Well, yeah, it is picture A still. Leading to cellular ballooning and eventual necrosis. Steatosis presents without evidence of significant inflammation or fibrosis, may persist or even regress over time, usually asymptomatic. Metabolic dysfunction associated with steatohepatitis associated with the lobular inflammation and hepatocyte ballooning, leading to fibrosis, may progress to cirrhosis and hepatocellular carcinoma. You also have one called autoimmune hepatitis. So let me go over that now. Autoimmune hepatitis, chronic inflammatory liver disease, more common in females, may be asymptomatic or present with fatigue, nausea, or pruritus, often positive for anti-smooth muscle or anti-liver kidney microsomal 1 antibodies. Labs are elevated ALT and AST. Histology is portal and paraportal lymphoplasmacytic infiltrate. Now what about hepatic encephalopathy? Cirrhosis leading to portosystemic shunts, leading to a decrease in ammonia metabolism, leading to a neuropsychiatric dysfunction which is reversible, ranging from disorientation and asterixis to difficult arousal or coma. Not fun. Triggers include increased ammonia production and absorption due to the GI bleed, constipation, or infection, or a decreased ammonia removal due to renal failure, diuretics, bypassed hepatic blood flow, post-TIPS. Treatment would be lactulose, increased NH4, ammonium or whatever, and ammonium generation, rifaximin, decreased ammonia producing gut bacteria. Okay. And that's not a good sign when you get hepatic encephalopathy. What about liver tumors? We're talking about liver tumors now. I have under that hepatic hemangioma, focal nodular dysplasia, hyperplasia, hepatic adenoma, hepatocellular carcinoma. So let's talk about it. Liver tumors, hepatic hemangioma. Hepatic hemangioma, also called the cavernous hemangioma, which you have in your book right there. Most common benign liver tumor, venous malformation, typically occurs at ages 30 to 50 years, biopsy contraindicated because of the risk of hemorrhage. Focal nodular hyperplasia, second most common benign liver tumor, occurs predominantly in females aged 35 to 50 years of age. Hyperplastic reaction of hepatocytes to an aberrant dystrophic artery marked by central stellate scar, usually asymptomatic and detected incidentally. Hepatic adenoma, rare, benign tumor often related to oral contraceptive or anabolic steroid use, may regress spontaneously or rupture, abdominal pain and shock. Hepatocellular carcinoma. Hepatocellular carcinoma, also called a hepatoma, most common primary malignant liver tumor in adults, associated with the HBV plus or minus cirrhosis and or all other causes of cirrhosis, including HCV, alcoholic and non-alcoholic fatty liver disease, autoimmune disease, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, and specific carcinogens like aflatoxin from aspergillus. Findings include anorexia, jaundice, tender hepatomegaly, may lead to decompensation of the previously stable cirrhosis, for example, ascites, and portal vein thrombosis. Spreads hematogenously. Diagnosis, ultrasound, screening, or contrast, CT, MRI. Confirmation would be biopsy if diagnosis is uncertain, recurrence monitored if serum AFP. And you can see, for example, the tumor right there in A, and you can see, for example, in the picture B, the actual CT, MRI. Then we're going to go into hepatic angiosarcoma, which I don't think I have in this PDF, but let me read it out. Hepatic angiosarcoma, rare malignant tumor of endothelial origin associated with the exposure to arsenic, vinyl chloride. Then we have metastasis, most common malignant liver tumors overall. So the most common malignant liver tumors overall are metastases, not endogenous ones necessarily. The most common kind is the metastatic type. Primary sources include GI, breast, lung cancers. Metastases are rarely solitary, so you'll probably find more than one. Alpha-1 antitrypsin deficiency. Misfolded gene product protein aggregates in hepatocellular ER, leading to cirrhosis with PAS positive globules. And you can see a picture of that right there in liver. Codominant trait often presents in young patients with liver damage and dyspnea without a history of tobacco smoking. In lungs, decrease in alpha-1 antitrypsin leads to uninhibited elastase in alveoli, leading to elastic tissue, leading to pan-acinar emphysema. So when you have centroacinar emphysema, it's smoking. It's going to be found in the upper lobes. But when you have a lower lobe pan-acinar emphysema that's related to alpha-1 antitrypsin, which also causes issues right here, obviously for the liver itself as well, in addition to the lungs. What about jaundice? Abnormal yellowing of the skin and or sclera icterus due to the bilirubin deposition. Hyperbilirubinemia secondary to the increased production or decreased clearance, impaired hepatic uptake, conjugation, or excretion. And there's a little learning device here, hot liver, commonly caused by elevated bilirubin. So you have hemolysis, obstruction, tumor, and liver disease. So these are the causes. Unconjugated indirect hyperbilirubinemia. Unconjugated type, we're talking about hemolytic benign neonates, Crigler-Najjar syndrome, and Gilbert syndrome. They call it Gilbert. Technically, it's pronounced Gilbert syndrome, but it's spelled Gilbert. So I'll honestly, if you talk about it in the field, I imagine they would probably more likely to call it Gilbert than Gilbert, but whatever. Mixed hyperbilirubinemia. Both direct and indirect hyperbilirubinemia, hepatitis, cirrhosis. What about benign neonatal hyperbilirubinemia? I think that's just what we're talking about right here. With that, okay, so let me see. It's benign neonatal hyperbilirubinemia, formerly called the physiologic neonatal jaundice, mild unconjugated hyperbilirubinemia caused by increased fetal RBC turnover, which is an increased hematocrit and a decreased fetal RBC lifespan. Immature newborn liver with a decreased UDP glucosuroneal transferase activity. Sterile newborn gut with a decreased conversion to urobilinogen, leading to an increase in deconjugation by intestinal brush border, beta-glucuronidase, leading to an increase in enterohepatic circulation. Beta-glucuronidase, lysosomal enzyme for direct bilirubin deconjugation, also found in breast milk, may lead to pigment stone formation. Occurs in nearly all newborns after 24 hours of life and usually resolves without treatment in the 1 to 2 weeks, exaggerated forms. Breastfeeding failure of jaundice. Insufficient breast milk intake leading to a decrease in bilirubin elimination in the stool, which leads to an increase in enterohepatic circulation. Breast milk jaundice. Increase in beta-glucuronidase in breast milk, leading to a increasing deconjugation, leading to an increase in enterohepatic circulation. Severe cases may lead to kernicterus, deposition of unconjugated lipid-soluble bilirubin in the brain, particularly the basal ganglia. How do you treat it? Phototherapy, non-UV, isomerizes the unconjugated bilirubin to water-soluble form that can be excreted in the bile. Biliary atresia, if we can find that in here. Maybe not, maybe not. Biliary atresia, most common reason for pediatric liver transplantation, fibro-obliterative destruction of the bile ducts leading to cholestasis, associated with the absent/abnormal gallbladder on ultrasonogram, often presents as a newborn with persistent jaundice after 2 weeks of life, darkening urine, alcoholic stools, hepatomegaly. Labs will have an increased risk of bilirubin and GGT. Gilbert syndrome, Now we're talking about hereditary hyperbilirubinemia. So hereditary hyperbilirubinemia. These are all autosomal recessive, according to this. Maybe Rotor syndrome, which is in my book, might not be, but the other three, the first three that you see here, are all autosomal recessive, certainly. So Gilbert or Gilbert syndrome, mildly decrease in UDP glucuronidase transferase conjugation, asymptomatic or mild jaundice, usually with stress, illness, or fasting, with increased unconjugated bilirubin without overall overt hemolysis. Relatively common, benign condition. Crigler-Najjar syndrome type 1. Absent UDP glucuronidase transferase, presents early in life, but some patients may not have neurologic signs until later in life. Findings include jaundice, kernicterus, which is unconjugated bilirubin deposition in the brain, increased unconjugated bilirubin. Treatments would be plasmapheresis and phototherapy. It does not conjugate the UCB, but it does increase the polarity and increase the water solubility to allow excretion. Liver transplant is curative, though. Type 2 is less severe and responds to phenobarbital versus type 1, which is more severe, with which increased liver enzyme synthesis. Dubin-Johnson syndrome. Conjugated hyperbilirubinemia due to defective liver excretion. Grossly black, dark to liver due to impaired excretion of epinephrine metabolites, benign. Rotor syndrome, ROTOR. Phenotypically similar to Dubin-Johnson syndrome, but milder presentation without the black, regular liver due to impaired hepatocyte storage of conjugated bilirubin. Oh, they do have Rotor syndrome in here as well, so these are all autosomal recessive. And here's a little diagram showing that stuff right here. Showing up Kupffer cell, space of Dis, unconjugated bilirubin, conjugated bilirubin via the steps 1 and 2. And that's where those two diseases act on. That's where those diseases act on 1, 2, 3, and 4, where they're acting on different parts of the actual cycle of with bilirubin involved, that kind of thing. So you can look through that to see what part of the process that they're going to impair. Okay, now we're going to go into Wilson's disease, I believe. Wilson's disease. And now we're on page 402, and we wrap up on 408, I believe. Yeah, so 408, right? Yeah, 408, okay. Wilson's disease, also called hepatolenticular degeneration, autosomal recessive mutations in the hepatocyte copper transporting ATPase, ATP7B gene, chromosome 13, leading to a decrease in copper incorporation into the apoceruloplasmin and the excretion into the bile, leading to a decrease in serum ceruloplasmin. Copper accumulates especially in the liver, brain, specifically basal ganglia, the cornea, the kidneys, and an increase in urine copper. Presents before age 40 with liver disease like hepatitis, acute liver failure, cirrhosis, neurologic disease like dysarthria, dystonia, tremor, Parkinsonism, psychiatric disease like Kaiser-Fleischer ring, which you see in the eyes, as you can see right there, deposits in the decimet membrane of cornea, hemolytic anemia, renal disease, Fanconi syndrome. How do you treat it? Chelation with penicillamine or trientine, oral zinc, liver transplant, and acute liver failure related to Wilson disease. Hemochromatosis, autosomal recessive mutation in the HFE gene located on the chromosome 6, leads to abnormal low hepcidin production, increased intestinal iron absorption. Iron overload can also be secondary to chronic transfusion therapy like beta thalassemia major. Iron accumulates especially in the liver, pancreas, skin, heart, pituitary joints. Hemosiderin iron can be identified on the liver MRI or biopsy with Prussian blue stain, as you can see in picture A. Presents after age 40 when total body iron is greater than 20 grams. Iron loss through menstruation slows progression in females. Classic triad of cirrhosis, diabetes mellitus, skin pigmentation, bronze diabetes. Also causes restrictive cardiomyopathy classic or dilated cardiomyopathy, which is reversible. hypogonadism, arthropathy, calcium pyrophosphate deposition, especially in metacarpophalangeal joints. Hepatocellular carcinoma is most common cause of death. Hepatocellular carcinoma is the common cause of death. Or is a common cause of death. It just says is common cause of death. Okay, for people with hemochromatosis. Treatment for repeated phlebotomy, iron chelation with deferoxamine, and deferoprone. So remember that ferrum, iron, right? Ferrum, that's why it's Fe. And D means to remove, to defenestrate, to defeat, may not be the best one, but D as in to deconstruct, something like that, to be destructive. So D in defer, in this case refers to removing of iron, so deferoxamine, and deferoprone. What about biliary tract disease? For biliary tract disease, we have may presents with pruritus, jaundice, dark urine, light-colored stool, hepatosplenomegaly, typically with cholestatic patterns of LFTs with increased conjugated bilirubin and increased cholesterol, increased ALP, and increased GGT. So we have three different types. We have primary sclerosing cholangitis, primary biliary cholangitis, and secondary biliary cholangitis. Primary sclerosing cholangitis. Unknown cause of concentric onion skin bile duct fibrosis leading to alternating strictures and dilation with beating of intra and extrahepatic bile ducts on the ERCP, which is shown in the picture. Oh, no picture for you. Okay. Magnetic resonance, cholangiopancreatography, and RCP. The epidemiology, classically middle-aged males with ulcerative colitis. Additional features associated with the ulcerative colitis, MPO-ONCA, P-ONCA positive, with increased IgM, can lead to secondary biliary cirrhosis, increased risk of cholangiocarcinoma, and gallbladder cancer. Primary biliary cholangitis. Autoimmune reaction leading to a lymphocytic infiltrate plus or minus granulomas, leading to a destruction of lobular bile ducts, classically in middle-aged women. Additional features would be antimitochondrial antibody positive, increase in IgM associated with other autoimmune conditions, Hashimoto thyroiditis, rheumatoid arthritis, celiac disease. Treatment would be ursodiol for that. Secondary biliary cirrhosis. Extrahepatic biliary obstruction leading to an increase in pressure in the intrahepatic ducts, leading to an injury/fibrosis and bile stasis. Patients with known obstructive lesions like gallstones, biliary strictures, and pancreatic carcinoma. This may be complicated by acute cholangitis. And your book says ascending cholangitis. I'm going to take a short break again. Okay, now on to cholelithiasis and related pathologies. Increase in cholesterol and or bilirubin, decreased bile salts, and gallbladder stasis all cause sludge or stones. Two types of stones. Cholesterol stones, which is shown in the picture A, radiolucent with 10 to 20% opaque due to calcifications, 80% of stones associated with obesity, Crohn's disease, advanced age, estrogen therapy, multiparity, rapid weight loss, medications like fibrates, race, for example, increased incidence in white and Native American populations. Okay, pigment stones, which are black, which are radiopaque, calcium bilirubinate, hemolysis, brown equals radiolucent infection. Associated with Crohn's disease, chronic hemolysis, alcoholic cirrhosis, advanced age, biliary infections, total parenteral nutrition, TPN. Most common complication is cholecystitis, can also cause acute pancreatitis, acute cholangitis. Diagnose of ultrasound, treat with elective cholecystectomy if symptomatic. Risk factors include 8 Fs. These are just this is a learning device here. Your book says 4 Fs, mine has 8. Female, fat, fertile, 40, fair, feeds, fasting, fibrates. So women who are overweight, have had lots of children, 40 or over, light skin, using total parenteral nutrition, fasting, they're experiencing rapid weight loss, and they're using fibrates, like fenofibrate, for example. Okay. My book has a little diagram explaining, sex, female, age, obesity, genetics, decreased cholesterol, 7-alpha hydroxylase leading to elevated cholesterol, decreased bile salts, gallbladder stasis leading to supersaturation of bile with cholesterol, leading to cholesterol stones. And then also says here, chronic hemolysis, biliary tract infection, leading to unconjugated bilirubin, gallbladder stasis, which leads to supersaturation of bile with calcium bilirubinate, which leads to pigment stones. Now we're talking about related pathologies and characteristics. So biliary colic, associated with the nausea/vomiting and dull right upper quadrant pain. Neurohormonal activation, like by CCK after a fatty meal, triggers contraction of the gallbladder, forcing stone into the cystic duct. Labs are normal. Ultrasound shows cholelithiasis. Cholelithiasis, presence of gallstones in common bile duct, often leading to elevated ALP, GGT, direct bilirubin, and or AST/ALT. Cholecystitis, acute or chronic inflammation of gallbladder. Calculus cholecystitis, most common type due to gallstone impaction in the cystic duct resulting in inflammation in gallbladder while thickening, which is should be shown in the picture. Mine does. I guess the yours does not. I'm not sure. Can produce secondary to infection. Acalculous cholecystitis due to gallbladder stasis, hypoperfusion, or infection of CMV seen in critically ill patients. Murphy sign, inspiratory arrest on right upper quadrant palpation due to pain. Pain may radiate to the right shoulder due to irritation of the phrenic nerve. Increase in ALP if bile duct becomes involved, acute cholangitis. Diagnosis of ultrasound and cholecystography, hydroscan. Failure to visualize gallbladder on hydroscan suggests obstruction. Gallstone ileus. Gallstone ileus, fistula between the gallbladder and the GI tract. Stone enters the GI lumen and it leads to obstruction at the ileocecal valve, which is the narrowest point. Pretty crazy stuff. It goes to the fistula, pretty wild. Can see air in the biliary tree, pneumobilia, Wriggler triad, radiographic findings of pneumobilia, small bowel obstruction, and a gallstone, usually in the iliac fossa. What about porcelain gallbladder? Porcelain gallbladder right here. Calcified gallbladder due to chronic cholecystitis, usually found incidentally on imaging, as you can see in the picture D right there. Treatment would be prophylactic cholecystectomy, generally recommended due to an increased risk of gallbladder cancer, mostly adenocarcinoma. And we have an ascending cholangitis, which my book says acute cholangitis. It says here acute cholangitis, also known as ascending cholangitis. Infection of biliary tree, usually due to an obstruction that leads to stasis or bacterial overgrowth. Charcot triad of the cholangitis includes jaundice, fever, and right upper quadrant pain. Raynaud's pentad is the Charcot triad plus ultramental status and shock, hypotension. Now we have something called cholangiocarcinoma. Somewhere. Oh, well, maybe not. I'll read this out. Cholangiocarcinoma, malignant tumor of the bile duct epithelium. Most common location is a convergence of right and left hepatic ducts. Risk factors include primary sclerosing cholangitis, liver fluke infections like Clonorchis sinensis. They say Clonorchis. I would say Clonorchis sinensis is particularly what the issue is. But Clonorchis usually presents late with fatigue, weight loss, abdominal pain, jaundice. Imaging may show biliary tract obstruction. Histology would be infiltrating neoplastic glands associated with the desmoplastic stroma. Now we're talking about pancreatitis. So we have acute and chronic. Acute pancreatitis. Autodigestion of pancreas by the pancreatic enzymes. And you can see that in picture A. A shows pancreas, yellow arrows, surrounded by edema, which are in the red arrows. Causes include idiopathic, gallstones, ethanol, trauma, steroids, mumps, autoimmune disease, scorpion sting, hypercalcemia, hypertriglyceridemia, greater than 1,000 mgdl, ERCP, drugs, sulfa drugs, NRTIs, protease inhibitors. It says, I get smashed. Okay, well, I don't know if I disavow, but okay. That's mnemonic there. IGETSMASHHED. Okay. Idiopathic gallstones, ethanol, trauma, steroids, mumps, autoimmune, scorpion sting, hypercalcemia, hypertriglyceridemia, ERCP, drugs. Okay. Diagnosis by two or three criteria: acute epigastric pain, often radiating to the back, serum amylase or lipase, more specific to 3 times the upper limit of normal, or characteristic imaging findings. Complications: pancreatic pseudocyst, lined by granulation tissue, not epithelium, abscess, necrosis of parenchymal or parapancreatic tissue, hemorrhage, infection, organ failure, ALI, ARDS, shock, renal failure, hypocalcemia, precipitation of calcium soaps. Oh, so it's like talking about, precipitation of calcium soaps. So like saponification. Okay. Precipitation of calcium soaps. Chronic pancreatitis. Let's talk about that now. Chronic inflammation, atrophy, calcifications of the pancreas, which is shown in picture. It's pretty obvious for your book, to be honest with you. You can tell which one's which. Major risk factors include alcohol use disorders and genetic predispositions. Example, cystic fibrosis, SPINK1, which is SPINK1 mutations, can be idiopathic. Complications include pancreatic insufficiency and pseudocysts. Pancreatic insufficiency, typically when less than 10% of pancreatic function, may manifest with steatorrhea, fat-soluble vitamin deficiency, and diabetes mellitus. Amylase and lipase may or may not be elevated, almost always elevated in acute pancreatitis. Pancreatic adenocarcinoma. Right here. This is the last part before we go to pharmacology. So pancreatic adenocarcinoma, very aggressive tumor arising from the pancreatic ducts, disorganized glandular structure with cellular infiltration, often metastatic at presentation, with average survival of 1 year after diagnosis. Tumors more common in pancreatic head, as you can see in the picture B, leading to obstructive jaundice associated with the CA19-9 tumor marker, also called CEA, less specific. Most common genomic abnormality is KRAS activating mutation. Risk factors include tobacco smoking, strongest risk factor, chronic pancreatitis, especially greater than 20 years, diabetes, and age greater than 50. Often presents with abdominal pain radiating to the back, weight loss due to malabsorption, anorexia, migratory thrombophlebitis, redness and tenderness on the palpation of extremities, Trousseau syndrome, and obstructive jaundice with palpable non-tender gallbladder, Courvoisier sign. This is the best way I can pronounce it, but you can see on your screen exactly what it looks like. And for this, they say treatment in your book, I don't have it in mind, but it says treatment here: Whipple procedure, chemotherapy, radiation therapy. Okay, and that concludes the pathology section of the gastrointestinal chapter. Going on now to pharmacology, and I will probably take a short break. Yeah, probably not a long break, but maybe a short break. You might have to skip forward a little bit. Okay, let's go on to the gastrointestinal section on pharmacology. Or I should say, the pharmacological section of the gastrointestinal chapter. Acid suppression test. That just shows you some various different kinds of things going on with ACH acetylcholine going to the M3 receptor, gastrin going to the CCK receptor, histamine going to the H2 receptor, somatostatin going to, some receptor related to G sub I, and prostaglandins going to some receptor related to G sub I as well. That's probably going to be useful, potentially, possibly for you. And also showing different drugs like antacids, PPIs, sulcrafate, bismuth, misoprostol, H2 blockers, atropine, so forth. So if you want to go take a screenshot of that and put it in your book, knock yourself out. Go right ahead. Okay, and now we're on 406 in this book, which we wrap up on, again, on 408. So we're on the tail end right now. H2 blockers, cimetidine, famotidine, nizatidine. They take H2 blockers before you dine. This is the learning device. Take H2 blockers before you dine. Think table for two to remember H2. Okay. Sure. I would remember them as being antihistamines, which are affecting H2. Not too complicated. They're affecting the parietal cells, which make the protons. How do they work? Mechanism: reversible block of the histamine H2 receptors, leading to a decrease in hydrogen these proton secretion by the parietal cells. Clinical use: peptic ulcer, gastritis, mild esophageal reflux. Adverse effects: cimetidine is a potent inhibitor of the cytochrome P450, multiple drug interactions. It also has the anti-androgenic effects: prolactin release, gynecomastia, impotence, decreased libido in males, can cross the blood-brain barrier, confusion, dizziness, headaches, and placenta. Cimetidine decreases renal excretion of creatinine. Other H2 blockers are relatively free of these effects. Proton pump inhibitors: omeprazole, lansoprazole, esomeprazole, pantoprazole, dexlansoprazole. So I think you can figure out what the actual suffix related to these are. Mechanism: irreversibly inhibits the hydrogen potassium ATPase in the stomach parietal cells. They do that directly. It's irreversible. Clinical use: peptic ulcer, gastritis, esophageal reflux, Zollinger-Ellison syndrome. Component of therapy for the H. pylori treatment. Stress ulcer prophylaxis. Adverse effects of PPIs: increased risk of C. difficile infection, pneumonia, acute interstitial nephritis, vitamin B12 malabsorption, decrease in serum magnesium calcium absorption, potentially leading to increased risk of fractures in older adults. What about antacids? Let's go down. Antacids. Antacids can affect reabsorption, bioavailability, or urinary excretion of other drugs by altering the gastric and urinary pH by delaying gastric emptying. All can cause hypokalemia. Aluminum hydroxide, constipation, hypophosphatemia, osteodystrophy, proximal muscle weakness, and seizures. This is the learning device: aluminum amount of feces, CHOPS. I have no idea what that. I don't know. Whatever. But aluminum hydroxide, that's for constipation, hyperphosphatemia, osteodystrophy, proximal muscle weakness, and seizures. Okay. What about calcium carbonate? I'm assuming these are referring to what they do, or what they're used for. Calcium carbonate. Am I sure? I don't know. These might be the side effects. So aluminum hydroxide, constipation, hyperphosphatemia, osteodystrophy, proximal muscle weakness, seizures. I would imagine it's probably actually the side effects, probably. So that's the side effects. Calcium carbonate side effects: hypercalcemia, makes sense. Milk alkali syndrome, rebound acid increase. It can chelate and decrease the effectiveness of other drugs like tetracycline, by the way. Magnesium hydroxide, the side effects include diarrhea, hyporeflexia, hypotension, and cardiac arrest. And remember, magnesium must go to the bathroom, okay, because of diarrhea. What about bismuth sulfate? Bismuth sulfate mechanism binds to the ulcer base, providing physical protection and allowing for bicarb secretion to reestablish pH gradient in the mucus layer. Sulfate requires acidic environment, not given with PPI/H2 blockers. Clinical use is for increasing the ulcer healing. Traveler's diarrhea, bismuth. Bismuth also used in quadruple therapy for H. pylori. Misoprostol. Mechanism, a PGE1 analog, increasing the production secretion of gastric mucus barrier, decreasing acid production. Clinical use would be prevention of the NSAID-induced peptic ulcers. NSAIDs block the PGE1 production, also used off-label for induction of labor, ripens the cervix. Okay. The adverse effects of misoprostol: diarrhea, contraindicated in patients of childbearing potential, abortifacient. So yeah, it unfortunately does also have the potential for causing, inducing a miscarriage, essentially. Octreotide. Mechanism: long-acting somatostatin analog, inhibits the secretion of various splanchnic vasodilatory hormones. Clinical use would be acute variceal bleeding, acromegaly, VIPoma, and carcinoid tumors. The adverse effects would be nausea, cramps, diarrhea, increased risk of cholelithiasis due to CCK inhibition. Sulfasalazine, mechanism would be a combination of sulfapyridine, antibacterial, and a 5-amino salicylic acid, anti-inflammatory, activated by colonic bacteria. Clinical use would be ulcerative colitis, Crohn's disease, colitis component. The adverse effects would be malaise, nausea, sulfonamide toxicity, and reversible oligospermia. Loperamide and diphenoxylate, mechanism would be agonists at the mu-opioid receptor, leading to a decrease in gut motility, poor CNS penetration, low addictive potential. Clinical use would be diarrhea. The adverse effects include constipation and nausea. So your book goes into ondansetron. I'm going to go into antiemetics. So we're talking about, talking about some of the same stuff. So antiemetics all act in chemoreceptor trigger zone of the area prostrema. The drug, mechanism, clinical use, and adverse effects. So ondansetron and granisetron. They are 5-HT receptor antagonists. They also act peripherally to decrease fecal stimulation. They are used for nausea and vomiting after chemotherapy, radiotherapy, or surgery. But they can cause headaches, constipation, QT interval prolongation, and serotonin syndrome. Another drug would be prochlorperazine and metoclopramide. These are D2 receptor antagonists. Metoclopramide also causes an elevated gastric emptying and an increase in the lower esophageal sphincter tone. These are used for nausea and vomiting. Metoclopramide is also used in gastroparesis, for example, diabetic, persistent GERD. But they can cause extrapyramidal symptoms, EPS, hyperprolactinemia, anxiety, drowsiness, restlessness, depression, and GI distress. Aprepitant and fosaprepitant, these are NK1 neurokinin 1 receptor antagonists. NK1 receptor, substance P receptor. They are used for chemotherapy-induced nausea and vomiting, but they can cause fatigue and GI distress. What about orlistat? Orlistat mechanism inhibits the gastric and pancreatic lipase, leading to a decrease in breakdown and absorption of the dietary fats, taken with fat-containing meals. They are used for weight loss, but the adverse effects include abdominal pain, flatulence, bowel urgency such as frequent bowel movements, and steatorrhea, leading to a decrease in absorption of the fat-soluble vitamins. And now we're going to go on to anti-constipation drugs, which I think they call probably laxatives in your book. Preptent's right there, by the way. So my book, anti-constipation drugs. We have drug, mechanism, adverse effects. So bulk-forming laxatives, methylcellulose and psyllium. These are used. Are soluble fibers that draw water into the gut lumen, forming a viscous liquid that promotes peristalsis, but they can cause bloating. Osmotic laxatives, lactulose, magnesium citrate, magnesium hydroxide, and polyethylene glycol. They provide osmotic load to draw water into the GI lumen. Lactulose also treats hepatic encephalopathy. Gut microbiota degrades lactulose into metabolites, lactic acid and acetic acid, that provide nitrogen excretion NH4 positive or ammonium by trapping it in the colon. Adverse effects include diarrhea, dehydration, and may be misused by patients with bulimia. Okay, because they want to try to lose weight. They want to prevent themselves from gaining weight, but they still want to binge and stuff like that. So, stimulant laxatives like bisacodyl and senna, these are enteric nerve stimulation leading to colonic contraction, but they can cause diarrhea. Emollient laxatives, docosate, they are surfactants that decrease stool surface tension, promoting water entry into the stool, and they can cause diarrhea. Lubiprostone, chloride channel activator, which leads to increased intestinal fluid secretion, but can cause diarrhea and nausea. Notice a trend here. All these things basically cause diarrhea besides bulk-forming laxatives, which cause bloating. Although I wouldn't be surprised if they also cause diarrhea, just as I mentioned. But all the others certainly do cause diarrhea. So lubiprostone can cause diarrhea and nausea. So lubiprostone, chloride channel activator, increases intestinal fluid secretion but can cause diarrhea and nausea. Guanylate cyclase C agonists, linaclotide and pleclitide. Okay, linaclotide and pleclitide. These are guanylate cyclase C agonists. They activate intracellular cyclic GMP signaling, leading to an increase in fluid and electrolyte secretion in the intestinal lumen, but they cause diarrhea, bloating, abdominal discomfort, and flatulence. Serotonergic agonists, prucalopride, 5-HT4 agonism leading to enteric nerve stimulation, leading to increase in peristalsis and intestinal secretion, but it can cause diarrhea, abdominal pain, nausea, and headache. NHE3 inhibitor like tenapanor. Tenapanor, they inhibit the sodium-hydrogen exchanger, leading to a decrease in sodium absorption and increasing the water secretion in the lumen. They can cause, though, diarrhea, abdominal pain, and nausea. And that should conclude the sections 4 and 5, and therefore conclude the chapter on the gastrointestinal GI system, gastrointestinal system, for the first aid for the USMLE Step 1 2025 edition guide. So if you went through this entire stream and perhaps the previous one as well, hopefully they were of good use to you. Otherwise, I hope you have a great rest of your day. Thank you and goodbye.